All right, thank you very much for allowing us to present to you today. I'm presenting a study from the Children's Oncology Group, the Pediatric Cooperative Group of the National Cancer Institute, and this was a phase 3 trial, which randomized patients to the agent Gemtuzumab Ozogamicin on top of a standard backbone of chemotherapy. As you likely know, survival in pediatric acute myeloid leukemia has been gradually improving, as shown in the survival curves on top there. This has been due to both a combination of chemotherapy intensification as well as the incorporation of allogeneic stem cell transplant. As well, it has been improving because of better supportive care over the past decade. However, we do have limits to that escalation of therapy, and that is our toxic mortality has been quite high in the therapy of AML. Between 10 and 19% of patients die of fatal complications during their treatment. And this has been fairly consistent over the past decade. As well, many of the patients have a greater risk of late cardiac sequelae, with over 8% of patients, or a 27-fold increased risk of congestive heart failure over that of the general population because of exposure to the anthracyclines that are part of this chemotherapy. There's also a ceiling to our success. We still, despite the advances in this therapy, are only seeing event-free survival between 46 and 59%, and overall survival between 56 and 74% on the best of the chemotherapy regimens tested throughout the world. Now, as we look to improve our survival, one of the ways to do this is through targeted therapy. Of the many targets that you've heard about over the years, the target that we have been focusing upon was that of the CD33 cell surface antigen. This surface antigen is present on greater than 80 to 85% of AML patients' leukemia cells. To target this agent, we utilize the agent Gemtuzumab Ozogamicin, which is the first humanized anti-CD33 monoclonal antibody that's linked to a DNA toxin that causes single and double-stranded DNA breaks, and that toxin is calicheamycin. In the phase 1 trials that occurred in the late 1990s, we saw an overall remission rate in both adults and pediatrics of between 28 and 30% as a single agent. It was with this remarkable improvement in these otherwise refractory patients that the FDA approved this in their accelerated approval program as one of the first agents to go through that process in 2000. As part of that process of approval, it was required of the company, as well as, of course, our clinical and academic interest, to pursue phase 3 trials in newly diagnosed AML patients. The first of those trials, and ours as well, these trials all occurred simultaneously over the past decade. The first of these that were reported was back at the ASH meeting in 2009. At that meeting, it was unfortunately shown in a trial that has since had some criticism as far as its design, but nevertheless, it showed no benefit in complete remission, which was its primary endpoint. Because of that, the agent was voluntarily withdrawn from the market in 2010. However, 2 subsequent trials and 1 or 2 others that have been presented here at prior ASH meetings have shown that if you look at the endpoints of disease-free survival or reduced relapse risk, you in fact do see a benefit from this agent. This benefit seems to occur in the subgroups of AML, those patients with low risk or intermediate risk AML. We know that AML is a very heterogeneous disease, and thus do not expect one single agent to work in all patients. So This endpoint was what we had actually designed our study to look at. This was to improve event-free survival from the time of diagnosis, and we wanted to know if this varied by risk group or the method of intensification. The schema on the top right identifies that our patients were randomized at the time of study entry to receive 2 doses of Gemtuzumab, Ozogamicin, or GO, as abbreviated here, at a dose of 3 milligrams per meter squared per day, once on the first induction course on day 6 and the second on intensification day 7. We enrolled 1,070 patients over 4 years from 181 institutions throughout North America, Australia, and New Zealand. And for this analysis, we had 1,022 patients eligible. We now have a median follow-up of 3.5 years. What we saw was that the induction course was well tolerated, and we also did not see a significant benefit in complete remission. Now, that's not unusual. In our past children's oncology group trials, we've not seen benefits in complete remission. It's what occurs after remission, and that's what we saw as well. Now, going from the time of study entry, we did see a significant improvement in event-free survival with a hazard ratio or a reduced risk of events of 0.83. This equates to a 3-year event-free survival of 53 versus 47%. We, though, did not see a significant improvement in overall survival as shown by the figure above. Now, as I said, we wanted to look at what happened after remission. So we looked at 4 parameters, the first of which was, does this reduce the risk of relapse? And this certainly did. With a hazard ratio of 0.73 and a p-value of 0.01, this equates in real numbers to a reduced relapse risk of equates to a relapse risk, of 33% instead of 41% without the utilization of Gemtuzumab. However, we did see a slight increase in that risk of non-leukemic mortality, and overall our cumulative mortality at 5 years was 9% on the Gemtuzumab arm and 6% on the standard arm. We did see an improved disease-free survival, but our equivalent overall survival was also seen. So, as I said, in the adult trials, this seemed to vary by risk group. So our low-risk patients did see a marked decrease in their relapse risk, down to 20% compared to 30%. But this is the group where we did see some increase in their toxic treatment-related mortality. This was primarily infectious and later in the courses of therapy. Because of that, we did not see an improvement in their disease-free survival or overall survival. Our intermediate risk patients did not see any significant differences, though if we look at just our stem cell transplant patients, those who received a transplant with a matched family donor, we did see that they had significant improvements. And surprisingly, we did see an improvement in our high-risk patients of reduced relapse, improved disease-free survival, and improved overall survival. What's unique about our trial is, compared to the adults who never saw improvements in their high-risk patients, was that all of our patients with high-risk AML went to bone marrow transplant with best available donor, either a matched-related donor or, if that wasn't available, an unrelated donor. So, in conclusion, event-free survival was significantly improved with the utilization of Gemtuzumab. While there was no improvement in complete remission, we did see that relapse was consistently reduced in all risk groups, and in the intermediate risk and high-risk groups, this seemed to be limited to those with stem cell transplants. We did, however, see some increase in that toxic mortality. This seems to occur in the low-risk patients in later courses of therapy. Our current regimen actually does not use 5 courses of therapy as this past regimen did, but now 4. So we think our risk of infectious complications would be further reduced with that change. So CD33 targeting does reduce relapse risk, and we believe that merits further investigation. Thank you.